am delighted to hand things over to our moderator for the session, Jack Hammond, who is a retired U.S. Army Brigadier General with multiple extensive experience in so many different areas, multiple combat commands, and service to the military, and currently serves as the chief executive of the home-based National Center of Excellence for Mental Health and Brain Injuries, which he has led, really established, and has led for over a decade. Um, Really the first private sector center of excellence for the invisible wounds. And they have been developing and implementing innovative solutions for mental health and brain injuries for our service members and veterans, all provided at no cost to veterans and military service members and families. He has just done extraordinary work. He is a just a remarkable leader, in my view, one of the most extraordinary I've had the privilege of knowing. So, Jack, sorry, General Hammond, I'm gonna turn over this session to you. Thank you again for doing it.
Thank you, Jordan. And I just want to share what a true honor and privilege it's been working with this group, with you and Matt and others doing this important work. It's a true honor for me today to open up this important conversation. The issue of military and veteran suicide is one of the most urgent challenges we face today within the national security hemisphere. Over the past 2 decades, we've lost more than 150,000 service members and veterans to suicide. This is more than 20 times the number of that killed during our combat operations in Iraq, Afghanistan, and other places around the world. On average, we continue to lose roughly 20 veterans each day to suicide. Within the active duty force, suicide has become one of the leading causes for death, impacting not just the individuals we lose, but their families, their units, and the very fabric of our military community. What makes this crisis so complex is that there is no single cause, and therefore no single solution. The invisible wounds of war, PTSD, traumatic brain injury, depression, substance use, all intersect with the stresses of military life, repeated deployments, and the difficult transition back to civilian life. Add to that the unique culture of the military, where stigma and silence all too often keep men and women from reaching out. And these are very self-reliant people that really can't accept, that oftentimes can't accept this and look at this as a personal failure. But while the problem is daunting, it is not without hope. Advances in science, from predictive models of risk to resilience training and evidence-based treatments, are helping us to identify who is most vulnerable and how to best intervene. Programs across the Department of Defense, the VA, and research institutions are moving us forward into earlier detection, stronger prevention, and better care. That is why today's conversation is so important. We have brought together some of the nation's foremost experts, leaders whose work is shaping the future of suicide prevention in the military and veteran community. Their insights will help us better understand the scope of the challenge and, more importantly, the path forward to saving lives. We are honored to be joined today by four of the nation's leading experts in military mental health and suicide prevention. Dr. Bob Ursano is a professor of psychiatry and neuroscience at the Uniformed Services University, founding director of the Center for the Study of Traumatic Stress, and retired Air Force colonel. He has spent his career at the forefront of military and disaster psychiatry. Dr. Amy Adler is a senior scientist at the Walter Reed Army Institute for Research and a leading authority on resilience training and behavioral health leadership in that military context. Dr. Ron Kessler is the McNeil Family Professor of Healthcare Policy at Harvard Medical School and one of the most cited psychiatric epidemiologists in the world. He has led landmark studies, including the National Comorbidity Survey and Army STARS. Dr. Brian Marx is a professor of psychiatry at the Chobanian, and I'm butchering both of these and I apologize, Abadigian School of Medicine, and staff psychologist at the National Center for PTSD at VA Boston. His research has shaped evidence-based treatments for PTSD and advanced suicide prevention efforts at the VA. We are deeply grateful to have such a distinguished panel with us today. Dr. Ursano, let's begin with you. Suicide has been a long-standing concern within the Department of Defense. What has been the concern about suicide in the DoD, and could you tell us more about the STARS program and its importance?
General Hammond, pleasure to see you again, number one, and glad to be here to participate in the panel. As many of you will know, that historically, the suicide rate within the military broadly, within the Army specifically, had been approximately half that of a similar gender and age matched cohort. However, beginning in about 2004, the suicide rate in the Army specifically and DoD generally began to increase. And generally it has increased through to around 2009, 2010, when it matched the suicide rate for a civilian comparative sample. Since that time, it has gone up slightly more and remains high. As General Hammond alluded to, illness in our military forces is a national security risk, whether that happens to be TBI or COVID or suicide. And that was the way this was approached. In 2004, the Army and NIMH joined together to try and better understand what was occurring in the rising rates. In 2009, a grant was awarded to our team to look at and better understand and identify opportunities for intervention, specifically with the Army. So since 2009, STARS, which stands for the Study to Address Risk and Resilience in Service Members, has been occurring. It's actually 8 separate studies. What I'm going to do is not tell you content, I'll allude to some of it, but to tell you about the study itself. I'd refer you to, and these are contained in the documents that are there with the conference itself, 2 spots. One is our Center for the Study of Traumatic Stress, cstsonline.org, where you can find a copy description of the more than 104 studies that STARS has published. And secondly, to ICPSR at the University of Michigan, where you can find our public use data. But let me go back to the study itself. Depending on how you count it, there are 8, 9, or 10 different studies contained with this collaboration with Dr. Murray Steen, Ron Kessler, James Wagner, and also with Dr. David Benedict and James Nafee, also at Uniformed Services University, along with many others, including Matt Knock. These studies represent different components of trying to understand suicide. Firstly is the historical administrative data. Perhaps one of the major achievements of STARS, both for the Army and for the nation, to have taken raw databases, 48 or 50 databases across the Army, and turned them into researchable data. We presently have data available through 2021, soon to be 2023, represents over 3 million soldiers, every soldier that has served in the Army since 2004. That data is all de-identified. All of these studies have gone through institutional review boards and, in fact, up through the Secretary of Defense in terms of ensuring protection for the soldiers and service members. So the HADS is now an amazing data set that brings together both administrative data, deployment data, medical data, as well as legal and forensic data, as well as other data sets on soldiers that have served. Secondly is the pre-post deployment study. This was a study of 3 brigade combat teams, before, shortly after, and then several times after that deployment, allowed for a longitudinal study specifically of deployment. Early on, one of the most important studies that STARS put out was to show that rates of suicide went up regardless of whether or not soldiers had ever deployed or had never deployed. So the deployment was not the answer. And as General Hammond said, there is no the answer. There are answers. But the pre-post deployment study was one important component in further delving into that particular question. Another important study, which is a foundation, there are really two of these, which are validation and verification studies. A clinical calibration study, which assured that our surveys, which are those that have been used widely in other epidemiologic studies, as well as a validation study looking at the Army's data on people that they called suicide and didn't call suicide, which showed that those determinations were very well. And our clinical calibration study allowed us to ensure that our assessments of mental health disorders in the surveys, which I will tell you about, were also accurate. The pre-post deployment study, survey-based study. Another new soldier study were assessments of soldiers just as they came into service, so that we could follow them longitudinally throughout their service in the administrative data sets. Next survey study was to assess the temperature of the Army at the particular time at which the surveys were being initiated, which were about 2010, 2011. That's the All-Army study, which was at 48 or 50 different sites around the globe, in which we administered surveys to active service members throughout the world and when they're going into and out of Iraq and Afghanistan. In addition, there are two smaller scale studies, SHOWS A, which looked at suicide attempters in medical centers, SHOWS B, an important study which looked at soldiers after they had died. So this is a post-mortem study, but in fact interviewed their friends, their family, and their service members. And importantly, there was a matched sample of service members with similar risk for suicide. So you could ask an NCO, did you notice X about this soldier? And then you could ask, did they notice X about the soldier who was still living who had similar suicide risk? There was also a neurobiologic component of the study, so that we have whole genome sequencing on a selected set of soldiers, which is also now available, requires funds to be able to access and draw the blood, but also available for further study. Neurocognitive assessments that were done on a large subsample of the study as well. So the most important present study is what we call the longitudinal study. We have continued to follow about 12 to 15,000 soldiers who participated in one of the baseline survey studies that I described to you, who are now surveyed about every 2 years. We're now in wave 5 of what we call the STARS LS longitudinal study. So what have we done with this data? How have we approached it? There are two major perspectives. What is, who is at risk? An old story. But when are they at risk? A somewhat new story, to realize risk is not static for people, even when they're in a high-risk group. And lastly, since we have a population that we know where they are, where are these people, literally, geographically? At the time, we know who they are, we know when they're at risk, what month of service, what age, and where are they located. We begin to be able to target individuals for interventions by knowing who, when, and where. Secondly, has been substantial work headed by Ronald's team on machine learning and predictive analytics. The perspective on this has been that of what's called concentration of risk. It's a concept well known to engineers who study airplane accidents. When you're studying rare events, it's very hard to intervene on them. So what you'd like to be able to do is to concentrate those events and to be able to intervene on the whole group that has a concentrated risk. So instead of having a needle in a big haystack, you have a needle in the smaller haystack. And then it's possible to think of interventions directed towards that group at risk. For example, one of the early studies that was done, perhaps the first ever, I'm not sure on that, but certainly one of the earliest ever done, which was to use concentration of risk to examine risk post-psychiatric hospitalization. When we did that, what we found is that we could identify soldiers who in the next 12 months, 4 out of 100 would be dead. That may seem like a small number, and what would we ever do with that? But I can tell you that for those of you familiar with statins and how they're used to lower cholesterol and heart disease, we give statins to 100 people in order to help 7.5 people. The other 92.5 people wouldn't have mattered at all whether they got them or not. To be able to do that, you have to have interventions that have low risk associated with them. We don't have an aspirin yet for suicide, but we can develop other interventions when we can, in fact, concentrate the risk among people to be able to identify them for interventions. A few of the other findings, and then I will pass back to General Hammond, just to keep you alert to them. Because we're studying a population and we have lots of data on them, we're able to look and see who actually commits suicide, documented suicide, verified suicide. And we also have surveys. So what percent of people actually get captured in the documented system? You can compare the surveys to, in fact, what we capture. And what we find is about 1/3 of suicide attempts are never seen. So we establish the rates of suicide attempt out of documentation, but we know from surveys that other suicide attempts are occurring that are never documented. That's not news when we think about it, but what is news is that we can come up with numbers associated with that, which is very hard to do in the civilian setting. Similarly, of interest early on was the finding that when soldiers come into the Army, half of them have already had a TBI. Our great concern on TBIs and how they occur while in the military, we need to recognize that soldiers bring with them particular risk and vulnerability factors. And is that surprising? Probably not. I mean, if you come into the Army, you probably play sports. You may actually parachute or skydive, or you've been hit in the head by a baseball. But those are not trivial events as we think across a lifetime. I'm sure there'll be more opportunities to talk about both stars and service members, and I look forward to the discussion. Back to you, General Hammond.
Thank you, Dr. Ursano. Dr. Adler, turning to you, your work has been instrumental in advancing resilience training for service members. What are you focused on right now in terms of universal resilience training, and how do you adapt this training to the unique demands of a military context?
Well, thank you very much. And this is going to be a little bit of a lift and shift away from focusing specifically on suicide, which Dr. Ursano and the previous talks have been describing. So this is really thinking about front loading all the good information that we have if people were to go to treatment, for example, and thinking about how do we take those key pieces of information and those key suggestions that clinicians have for service members or individuals who are at risk and package them in such a way that they can serve as mental skills that can be given to everybody. So really one of the ways that we're shifting and thinking about resilience training in the Army is, and in DoD in general, is packaging these skills and bringing them up front and making them prevention oriented. The way it's different in a military context compared to a civilian context is that we have an occupational health environment that's highly hierarchical. So the role of leaders is critical to understand in promoting anything that we offer or integrate into their training. And that's leaders at all levels, right? It's from the most immediate first line leaders on the enlisted side, going up through officers and even up at the higher, more senior levels. How they communicate about the resilience training, how they lead by example, what they choose to emphasize, whether they show up in training. We know from our own studies that there is an impact on the degree to which this material is taken up and implemented by service members and viewed as valuable. So leaders are critical. The other thing that's really critical is how we think about training individuals, because when we're training individuals in these sorts of skills, and I'll give an example in a minute, but when we're training individuals in these skills, we're training them for skills that the individual could use for themselves if they encounter distress or disappointment or have some sort of emotion regulation activity that they want to engage in to make themselves feel better. But they're also, because it's an occupational health context, we're also thinking about this in terms of how can they help their battle buddy, or in the Army now the phrase is just battle. How can they help their battle? And that's because within the culture, the real emphasis is not just on the individual, but it's on taking care of team members and taking care of one another. It's part of the ultimate kind of value system of no soldier left behind. It's true whether it's the Army or some other service, that this idea of being responsible to your teammate is really an essential piece. And I think a lot of the training that's out there in the civilian world doesn't really emphasize the role of the leaders, the role of the individual in terms of their responsibility to their battle or battle buddies. And then the kinds of materials that we're taking. So the DoD is so vast and there are so many programs. I just want to acknowledge, I'm just going to be hitting on some new research that we're doing, but there are multiple programs out there in terms of suicide prevention, in terms of resilience training across the services. The Army's in the midst of a pretty big change away from what had been its resilience training program and moving more towards holistic health and fitness. And I'm not necessarily the person to be speaking about all the big Army programs out there, but for those people who are interested, there are tons of big programs. It's a complex organization with lots of opportunity to make a difference. But in terms of the research, that's the piece that I'd like to speak to. We're really thinking in terms of how do you package emotion regulation skills in a way that service members can quickly and easily adapt them into their own lives. So one of the things that we've been doing is taking concepts such as temporal distancing, this idea of seeing a problem as temporary, something that might not matter as much over time, and teaching people how to use that by giving them a sticky way of thinking about it. So one of my colleagues, Major Jeff Osgood, he created a term, it's called 555. And we turned this concept of 555 into a 60-second animated video. And basically, the animated video shows a soldier who gets yelled at, is distracted and can't focus because they got yelled at by their supervisor. And then they ask themselves, how will they feel about this same event 5 weeks, 5 months, and 5 years from now? And our pilot data on this very simple little video is pretty positive. So we have soldiers who we ask them to recall a negative event. And then we ask them, how bad do you feel about it? Then we teach them 555, and then we check in with them again. And those who had an intensely negative experience, usually it's like they made a mistake or they got yelled at or they had some sort of conflict or they were embarrassed or felt left out, that their negative feelings drop by more than 50%, just through using this very simple, easy to absorb skill. And it's kind of like what you might see on a YouTube short, right? Something that's very easy to digest, very quick, tells a very simplified story. And really, just to be on the development side of these things, I will say it takes a long time to take what's known in the literature and shrink it down to 60 seconds and tell a little story. So it's actually harder to do it in a very short period of time than if I had like an hour to give a whole PowerPoint class. But really, the way soldiers are absorbing information, we want to meet them where they're at and not just do the traditional training that we might typically do. So we've used this approach with the little videos. And if people are interested, I can drop in the chat a place where they can go to see more of these videos. And we're now evaluating whether these videos can be used as a source of discussion for service members in their units, and whether leaders, along with behavioral health officers, can get together and have a discussion about it. We're taking all this kind of information and packaging it as well for our allies in Europe who are working with Ukrainian service members who are coming to Europe for training, particularly medics. Right now, Ukrainian soldiers go to Norway and other places throughout Europe, and they get trained in a 4-week to 5-week course in how to be a medic along with other specialty skills. And the Ukrainians have asked us to build in mental skills up front in that training and to spend several days on it. So there are 2 days dedicated to just this topic. And we've been taking kind of the lessons learned from DoD that we have research data on and publications on, packaging it for Ukraine, and then it's being evaluated with our allies. So I think the fact that we're taking this approach both for garrison within, what our own service members encounter, and thinking about how can we help not just our own service members, but service members who are in a very difficult position and trying to sustain their readiness. How can those same skills be useful? So there's a lot more where that comes from, but I'll pause there. Thank you very much.
Thank you, Dr. Adler. Dr. Kessler, you've been a key leader in the Army STARS program, and Dr. Ursano mentioned the predictive models developed by that team. Could you describe a couple of the most important of those models and how you determine if they work in practice and continue to work over time?
Yeah, sure. Well, as Bob said, we have 2 kinds of models. The first models are trying to pinpoint people at risk prior to the fact and get in front of the problem. And to the extent possible, if we find that those predictions are meaningfully accurate, unpack the fancy machine learning models, which are usually black boxes, to try to see, can we figure out what it was that was predictive, and can we get any insights about prevention from that. And the other kind of model is one that says we're making a clinical decision. We either have to do thing A or thing B, or treatments A, B, and C. Is there some way of using a machine learning model to compare the results, either based on a clinical trial or on a trial emulation from big data, to figure out what the right thing is for a particular individual? Because we know, particularly in the suicide realm, that there's no one intervention that works best for everybody. It's a much more complicated beast than a condition, because after all, suicide's not an illness, it's a symptom. So there are bipolar people who die by suicide, and schizophrenic people, and depressed people, and alcoholic people. So if we could figure out, and often treatment is a trial and error process. If we can get in front of it and try to get the right treatment to the right person right away, before having them get burned out and say, the hell with it, I'm giving up with this trial and error, I'm going to kill myself, then we can save lives. So a good example of the first one is some work we've been doing recently with Joe Garacci at the VA, who's working at Fort Knox, on suicide after leaving service. It turns out that the suicide rate jumps up very substantially when people separate from service. The transition from Army life into civilian life, there's a lot of structure in your life, and all of a sudden you're out there in the world again, and the suicide increases by about 50% in the first couple of years. So we've developed a model that takes all the administrative information we have about soldiers at the time of separating, and we link that up with the National Death Index to see, can we predict death after separation. And Chris Kennedy from MGH, from Jordan's group, has led this work. And we found that we actually could do a pretty good job. I forget the exact details, but it's about the 10% of separating soldiers who we say are at highest risk account for about 40% of all suicides. So it's a really enriched group. And Joe Garachi's people at the VA who are working with the TAP program, the Transitional Assistance Program in the Army, are using this at Fort Knox to pinpoint people before they separate who are at high risk and assign them a case manager to say, could we help you make that transition more successful? And Joe came to us and said, well, thanks for the model. You've told us who the people are, but could you tell us who they are? I mean, in a deeper sense, what are we supposed to do? Who are these high-risk people? Why are they high risk? And so we developed an interesting decomposition strategy and found that the people who our model find to be at high risk based on information while they're still in service, it turns out that when we follow them in the first couple of years out of service, in the STARS LS survey, we find that they have dramatically higher risk of having bad things happen to them. They get into more trouble with the police. They have more financial problems, more romantic problems. And we also find that compared to other people who have those problems, they're much more emotionally reactive. They're much more likely to get depressed or make a suicide attempt when they have a breakup with a girlfriend. So it's kind of a double whammy effect. People who are particularly bad at handling stress are particularly good at finding themselves ways of getting into stressful situations. So it doesn't give us any clues about what to do, but at least it helps the clinicians who Joe's team are working with to have insights into what's going on. So they're now developing programs that are particularly looking at, can you help figure out stress avoidance and stress management strategies? So that's a good example of one model. I'm probably out of time here. Is this the end of my time? I could sort of give you yeah. Okay, so it's sort of the 30-second version of the second model. We're working in emergency departments, and we're doing this with Brian Marx in the VA, where the standard of care for people who come in who are suicidal is that if you think they're going to die by suicide, you hospitalize them, stabilize them, and send them out with a treatment plan afterwards. But in fact, there's very little evidence that hospitalization reduces suicides. There have been several experiments. There have been some trial emulations. And using our STARS machine learning precision treatment methods, we developed a model from the VA data with Brian and his people that shows that what's going on is there's some people who are really helped by hospitalization and other people who are hurt by hospitalization. And our simulations suggest that if the people who make decisions about who to hospitalize obviously don't have in their brains what the computers have in their machine learning models, because there's virtually no association between what our models say should happen and what does happen. And again, just based on simulations, this model suggests that if hospitalization was done in the way we suggest, the number of people hospitalized would decrease by about 20%, because there's more people who aren't helped than are helped. And the suicide rate would also decrease by 15%. So it's a win-win situation in a world where we have a boarding crisis right now, where we don't have enough beds for people. Now, how do you know that this works? That was your beginning question. And the way you know is you try it out. So we are right now in the midst with Brian's team, led by several of the people who work for Brian, piloting, getting in place a pilot study to put this model in place in a series of VA emergency departments to test out in an experimental way whether it really works. And we will get back to us in 2 years and we'll let you know whether it works or not. That's how you find out. So that's the end.
Thank you, Ron. And finally, Dr. Marx. The VA has made significant investments in suicide prevention for at-risk veterans. Could you tell us about some of these programs and share your perspective on where you see the VA suicide prevention efforts heading in the future?
Absolutely. Thank you very much, General Hammond. And let me just start by thanking Doctors Knock and Smaller for inviting me to participate in this symposium and to provide some information about what's happening on the VA side. I guess I'll start by addressing the elephant in the room, and that is the kind of prevailing narrative that is out there about the VA. There's certainly this number that gets thrown around, about 17 veterans who die by suicide each day. And the VA is portrayed as being to be somewhat incompetent, I suppose, with respect to suicide prevention. The narrative, I would say, is a little bit more complicated than that. The 17 deaths by suicide per day, while that may be true, 60% of those who die by suicide have no connection to VA whatsoever. And that, I think, is a very important fact to keep in mind. The other thing I think to keep in mind is that VA has actually done quite a bit over the last several years in order to address these veteran suicides. If you look at the most recent annual report that comes out of VA's Office of Suicide Prevention, you'll see some very promising statistics, I would say. From 2021 to 22, the age-adjusted suicide rate for female veterans dropped by almost 25%, while actually the age-adjusted rate for female non-veterans actually went up by about 5%. There was a slight decrease in the suicide rate for younger veterans, and there was also an almost 20% decrease in the suicide rate for homeless veterans. And over about the last 2 decades, if you look, you'll see that there's actually been a decrease over time in the number of veterans who have a diagnosis of PTSD, depression, and anxiety-related disorder diagnosis. About for those people, it's about a 30 to 35% decrease over that period of time in terms of the number of people who are dying by suicide. Why is that happening? It's because the VA has invested a lot of time and energy and resources into lots of different things. You probably know about the Veteran Crisis Line. Dial 988 and press the number 1 and you get to someone who can help you if you're in crisis. This is a 24/7 resource. It's fielded millions of calls and texts and chats. And there's evidence to suggest that the VCL has actually been quite helpful to a lot of people. For every 1 veteran who dies by suicide despite the VCL efforts, about 200 veterans are prevented from dying by suicide because they are given emergency care. Another almost 300 are connected with one of our suicide prevention coordinators. There's the Compact Act, which has provided no-cost life-saving care to thousands of veterans who are at risk for suicide. Ron talked about ReachVet. ReachVet is a predictive algorithm that is used to identify veterans who may be at risk for dying by suicide and other adverse outcomes. The most recent version, there's a new update to ReachVet called ReachVet 2.0 that's about to be rolled out. It's supposed to be much improved from the initial version. There's safety plans in the emergency department. That's been rolled out, and it's led to a significant decrease among veterans who present in the emergency department dying by suicide. And of course, I would be remiss if I didn't mention the universal screening for suicide in VA. Since 2021, there have been approximately 15 million veterans who have been screened for suicide risk over the course of that time. So there's a lot that's been happening on the VA front. Now, obviously, that's good, that's helpful. It's impossible to quantify exactly how many veterans have been helped and how many suicide deaths exactly have been prevented by all of this. Obviously, 1 death is too many. And so the next step is to really move in the direction that Ron and Amy and Bob have been talking about here, and that others on this in this meeting have been really pioneering, and that is precision medicine. Obviously, to this point, there's been a one-size-fits-all approach in VA. And while that has been somewhat helpful, it can limit the impact and result in misdirection of resources. The VA, I would say, is really well positioned for a precision medicine approach to suicide prevention. Number one, they have a very large patient population. It's the largest healthcare system in the country. We have an electronic health record that is it's standardized, it's universal. All of the doctors who are involved in the care of the veterans communicate through this medical record. There are numerous data sets that are available for the purposes of engaging in all kinds of predictive analytic activities. And of course, we collect screening data across all of our different clinics and whatnot, as I mentioned just a second ago. So that, I would say, is really the next frontier here. Ron just laid out one of the projects that's ongoing. There are several that we could certainly talk about. But in the interest of time, I think what I would just say here is that with respect to the direction of the VA, there's really been, over the last 6 or 7 years, there's been a concerted effort to improve the coordination of activities to reduce redundancy. There's a lot of different pockets of researchers and folks within the Office of Suicide Prevention who are engaged in lots of different things. And what we need to do is really kind of work together rather than independently, and move us past these descriptive studies and more towards robust methods, such as what Ron was describing, clinical trials that take a precision medicine approach. We're in the process of curating and harmonizing data sets that we think will be very valuable in that regard, including data from the Veteran Crisis Line, which has really never been used before, but we're about to embark on a project using actual digitally recorded calls from the Veteran Crisis Line and do some really neat natural language processing work with it. And the whole point of it is to improve statistical power and really kind of see if we can impact care. The other thing on that last piece, and I'll turn it back to General Hammond, is in VA is unique in the sense that we have all of these activities going on, and we can actually then take all of the results of these studies and then inform the care that is being provided to our veterans and see if it helps. And we can actually have this sort of reciprocal relationship between research and clinical work where we can test out these new interventions or these modified interventions, these precision treatment rules, and make modifications along the way. Back to you. Thank you.
Thank you, Dr. Marx. Just a quick follow-up. In a moment ago, we talked about the fact that 60% of veterans who die by suicide are not in the VA care. And I think there's been several published findings on that. What do we do about well, first of all, that represents about 80,000 folks over the last 20 years. What do we do to get care to those folks?
I think that is an excellent question, and that's been the focus of some discussions that we've had within VA is how do we kind of get those veterans to bring them under the VA tent and get them the care that they need. One I think potentially important thing to keep in mind here is that some of those veterans who are outside of VA and who are not receiving VA care, they may not be eligible to receive VA care. And so we may have to expand the definition of eligibility in order to make sure that we get those folks the care that they need in order to prevent them from dying by suicide. But it's an excellent question. I don't know, other than trying to bring them within VA and provide them with the services that many of those who are in VA are getting, it becomes, I think, a real challenge, especially when you have folks all over the place getting all kinds of different care, and there's not a kind of a means to monitor and standardize the care that they're receiving.
Thank you. So I'm going to kick off the first question. Looking towards the future, recently Home Base launched a team to Ukraine and embedded within several clinics, and then in return, a team of Ukrainian clinicians came to Home Base and embedded for a few weeks. One of the lessons we learned is the impact of drone swarm. It is crippling, debilitating. Right now, Ukraine is producing about 4 million drones a year. Russia's bringing in 4 million drones a year. So everyone can just visually imagine an environment where armed drones are just flying everywhere, causing mayhem, killing, and injuring people. How do we prepare soldiers on the resilience side for an environment that is loaded with these drone swarms, causing deep psychological impact before anything even happens? And then obviously, will our current treatments still be effective to treat those type of injuries? And then finally, how will these drone swarms impact suicide in the future? Whether, the future effects of suicide.
I think I might jump in as the first person to answer this one, just from the military side. The question about drones is so topical and so critical, and there's so little that any of us understand about the best practices in dealing with it. There are a couple of things that are kind of we're currently working on, and I'll just highlight a few. One is to think about, it really shifts how we think about mental health on the battlefield and in recovery, because it isn't about anxiety anymore and managing anxiety. It's about fear, right? It's a reality-based actual threat. And I think that as mental health professionals, we don't typically talk about that or think about it in that way. But I think by asking that question, it kind of shifts how we have to think about mental health on the battlefield in performance as sustaining functioning. Second thing is just in terms of dealing with the immediate threat and what's can be described as an acute stress reaction. Basically, when somebody freezes or stops functioning for a period of time because they get kind of an amygdala hijack, they get so overwhelmed by mental stress that they can't function. There is efforts to create an intervention. Working with our allies in Israel, we developed an intervention. It's called iCover, little I COVER, and you can Google it. There's a little video if people are interested on YouTube. It basically teaches battle buddy support for what happens if somebody in your unit freezes in those moments. Ukraine has adapted that. They've translated it. They use it a lot. We get a lot of reports back of people using it. And in particular, they're using it when encountering drones. When one of their battle buddies freezes and doesn't move to safety, there's minimal opportunities for safety, but it's something to consider. And it's something that we can learn a lot about in terms of preparing our own service members. Ultimately, when our service members are dealing with these kinds of threats, it's going to have to be bigger than that. We're going to have to prepare them more than that. How we train them and how we integrate mental skills into tough, realistic training might be one way to begin thinking about this, but there's so much we don't know and so much opportunity for us to learn. The other thing I do want to mention, I'm conscious of the time and that other people might have things that they want to add, but the last thing I just wanted to mention is the previous presentations were talking a lot about mental health problems like depression and maybe PTSD, but I just want to highlight the potential for problematic anger to be something that needs particular attention in our context. It typically doesn't get a lot of attention because it doesn't have a direct correlate with a diagnosis, so it might get missed, but Army STARS has identified the critical role of problematic anger, as has a whole host of other new studies, in terms of adjustment for service members after they leave the military, and also in terms of suicide risk. So just something to think about as we move forward to make sure that we're equipping people with skills to manage anger and intense, long duration anger at what they might be encountering. Thanks.
I might add and kind of make the link to suicide in several ways. One, every war that's ever come up, there are new weapons. With the Iraq-Afghanistan war, IEDs were in fact a new weapon, and they stirred fear in everyone. We did a study in STARS to look at, did the number of IEDs relate to the rates of suicide and suicide attempts that were occurring? And the answer was yes. The more IEDs were going off, the more often there were suicide attempts happening. What was interesting about that study is that that correlation was present among people who had never deployed, let alone among people who were deployed. So there are the effects of the event itself, and then the effects of the propagation of fear. Secondly, I would highlight that the issue of IEDs highlight the issue of suicide and other, like PTSD, that are event-related problems. Something happens in life and we respond to it. Something happens and people decide to kill themselves. Something happens and people develop PTSD. This issue of understanding the translation of events to brain and behavior, and getting better at understanding the rapidity with which that happens, how rapidly people can go from ideation to attempt, highlights very much our needs for new ways of monitoring, new ways for intervening, and new ways of understanding the acute responses among people to move forward in a vast array of areas, including suicide.
Thank you. There's been a number of questions that have come in from attendees regarding stigma. I would share with you that certainly during the first several years of the wars, the stigma was prominent, as many senior leaders, mid-career leaders, didn't really understand post-traumatic stress, the impacts of traumatic brain injury, et cetera. I would submit that by 2010, 11, 12, so many of the senior leaders had been junior leaders and lost so many friends to suicide. I believe that stigma shifted to a point where more than not, leaders are encouraging folks to get the care they need. And certainly 20 years into the war, seeing the impact has enhanced that further. And leaders at the highest level of the military have been engaged in combat for 20 years and seen the impact on the force. Do we have any data regarding the impact of stigma? Because from a personal perspective, I think a lot of it has to do with the individual themselves, putting more on themselves with respect to a stigma of failing versus overhead stigma. But I would very much be interested to hear from you all on any data that you have that would indicate either way.
General Hammond, I'd make a couple of quick comments. In one important study that was done, and I believe it was Chuck Engel and Ron that you participated in, where one compared measures of stigma in the military to those in the civilian world. Number one, they're very similar. So when we think about stigma, it is a broad problem, certainly in the military, also outside. Secondly, I personally don't like the word stigma because it doesn't give us a way forward. However, thinking about barriers to seeking help, one of which can be admitting one has a problem or feeling weak in the face of others, gives us opportunities. And then lastly, I know one study that we did in STARS specifically, the most common reason for not seeking help was, I don't think I have a problem. And that was among people who eventually made a suicide attempt. So people recognizing when they have a problem is an important piece of that story of getting people to care.
I might also jump in and say that one of the concerns isn't traditional stigma. It's actually, General Hammond, something you mentioned earlier when you were introducing us, which is the preference for being self-reliant and the preference for self-management. So it may be less about rejection of the mental health community and what it has to offer because of being seen in some weak way, but rather they really want to be able to manage it on their own. So if that's the case, and there are some studies demonstrating that, what we want to do is package the material and provide them information that meets them where they're at and meets them in terms of their preference for self-management.
And I'll certainly just add that there's been a lot of work here in VA on barriers to care, and stigma, I suppose, is one of those things. I share Bob's, feelings about the word stigma. I think it's probably best to talk about it in a bit of a different light, although, stigma, I think everyone understands what that word means, but it carries such weight. And really, oftentimes what we're talking about is people feeling vulnerable and not wanting to admit that they're weak. And receiving care means that you have a weakness and that you're not capable of handling the problems yourself, as Amy was just saying. There are things that certainly we can do about that with patients here in VA, and there are people who do that work regularly.
Thank you. So one of the things we've seen at home base around suicide and folks that have reached that final level of injury is a loss of hope for a day without pain, a day without all of the anger they feel, etc. But that hopelessness feeling is something that is very pervasive. Contributing factors we see are pain, physical pain, years and years of injuries, self-medication, psychological pain, the loss of alignment with their tribe, sleep, the inability to sleep, something as simple as that. I'd be very interested to hear what your thoughts are on a more holistic approach that deals with these different exposures of military service that then lead to negative health outcomes. And when that cumulative collection of exposures and injuries comes together, is there a connection that leads to suicide? Is that a reasonable thought, or or is business as usual okay? And that may be a loaded question. I apologize for that.
I think the quick answer is absolutely. Many of the things, practically all of them, I think, are factors which identify those at risk of suicide. I know, Ron, recalling the specific work you did on, as you referenced, type 1, type 2 approaches to the treatment of sleep problems. And if you have a sleep problem, what are people going to do about it? The other piece that I would add to that is to recognize that we are much better at identifying people who have suicide ideation than we are at recognizing who among those who have suicide ideation will in fact make an attempt. And many of the factors that we identify are very good at identifying people with suicide ideation. Yet when we look among those with suicide ideation, being able to find factors that predict attempt, much more challenging, and certainly an important piece of work yet to be done.
I think the question, go ahead, Ron, I'll let you go.
Okay, thanks. I was going to say, there's really two pieces here. And Jack, you hit on the idea of hopelessness. Nobody chooses suicide as their favorite option for dealing with pain. And in the absence of pain, there's no reason for escape. There's something you have to escape from, and there's some ways you escape. And the two things to tackle in suicide prevention are: is there some way of relieving whatever that psychic or physical pain is? And in the absence of being able to do that, the clinical task is to say to a person that says, I want to kill myself because there's no other way out. That's the typical thing, is to say to them, there is other ways out. There's options we can show you that you haven't been thinking about. And clinical work in looking at the old psychoanalytic work of looking with people with suicide is this thing of defeasible explanations. I have 10 options here. I've tried 9 of them, and suicide is the only thing. You see that people who die by suicide in the 30 days before the suicide, there's an old series of studies showing that their number of phone calls goes up dramatically. They're reaching out. They're trying other things. And at a certain point, those options get constricted, at least psychologically. And the clinical task is to open up the perspective to see that there are other things. But there are really 2 ways of tackling this. How can we do practical things to make people's objective lives better? And then when we go as far as we can with that, how can we help them discover that, realize that killing themselves is not the only way out. I'm not a clinician, so I'm just good at predicting these kind of things, and that's why Bob and I have interesting conversations. But as he said, we're good at getting to that point of saying, here are the people who are at risk. Now, inside that group, how do we open up their options? That's one that's beyond me, but I turn to you clinical folks for that.
Well, I think that brings us to time. I want to thank you all for the extraordinary insights that you provided, for the work you do every day to save lives. Your research, leadership, and commitment are helping shape the future of military and veteran mental health and giving hope to those who need it most. And so with that, I want to thank you and turn it back over to Jordan, Dr. Smollett.